In cardiology, precision matters. Today, we explore how the Goal-Directed Valsalva maneuver helped reshape the diagnosis and treatment of a patient with hypertrophic cardiomyopathy. The Valsalva maneuver has long been used to provoke obstruction in hypertrophic cardiomyopathy, but traditional methods are inconsistent, and the research has shown that Goal-Directed Valsalva often elicits a higher gradient when compared to traditional Valsalva in patients with obstructive hypertrophic cardiomyopathy.
Goal-Directed Valsalva standardizes the effort. Achieving 40 millimeters of mercury of intraoral pressure and holding that for 10 seconds makes it reproducible and clinically reliable. So let's use a case study to further illustrate the effectiveness of Goal-Directed Valsalva.
So we had a 58-year-old male, Mr. J, who presented with exertional breathlessness and fatigue. His resting LVOT gradient was borderline, about 16 millimeters of mercury.
So we have a patient who's symptomatic but not meeting criteria for obstruction at rest, so we need a clearer picture. So we ask the patient to do Valsalva, where we get them to simply bear down, and we can see with that the mitral valve starts to move toward the septum, but we're not seeing septal contact.
Now, although the gradient goes up to about 29 millimeters of mercury, it's not quite enough really to explain the symptoms or be considered obstructive hypertrophic cardiomyopathy. So now we ask the sonographers to perform a goal-directed Valsalva during transthoracic echo, and you can see an abrupt increase. His gradient jumped up to 69 millimeters of mercury, confirming the suspicion this is dynamic obstructive hypertrophic cardiomyopathy.
So this reclassification is really pivotal. It confirms that this patient has dynamic obstructive hypertrophic cardiomyopathy, and it focuses our management strategy where we discuss various therapeutic options.
And over the next 12 weeks, his gradient dropped to 16 millimeters of mercury, improving his symptoms from New York Heart Association Class 3 all the way down to Class 1.
So Goal-Directed Valsalva also helped us to monitor therapy. So we were able to avoid unnecessary changes in the doses of his medications and also minimize imaging frequency.
So without Goal-Directed Valsalva, we might have missed the dynamic nature of this guy's obstruction. It changed everything from diagnosis all the way through therapy.
Yeah, it's a simple maneuver, but in hypertrophic cardiomyopathy, it really is transformative. Goal-Directed Valsalva should really be standard in evaluating patients for myosin inhibitor therapy. Goal-Directed Valsalva, bringing clarity to complexity and precision to patient care.